Thank you so much for that kind introduction. So, this afternoon, really, I have two parts to the presentation that I am going to be doing for you, and we'll take a break in between the two. Um, the first one is going to be sharing a little bit about some of the research that I have done. And it is what's called a pragmatic clinical trial, which means that it is much more focused on creating evidence-based practice research results. So things that we can use right away in practice. And then the second part of this afternoon, what I'm going to do is draw really from clinical experience working with oncology patients with chronic pain, because my academic appointment is in the College of Nursing and my clinical appointment is in the Cancer Center at UIC. And what I do is a lot of pain management there. So those are the two things that we're going to discuss a little bit today. And I hope that you will find it interesting. So the objectives of this first part of the talk is talking a little bit about the background on pain, describing, then I'm going to move to more the research part of it, which is describing some of the key characteristics of a pragmatic clinical trial. And then I'll conclude with walking you through this example of one of my research projects that was a pragmatic clinical trial. So again, this is going to be the first part of the lecture here. So the first learning goal for us this afternoon is understanding the background of pain. And what pain is the definition, is an unpleasant sensory and emotional experience. And the tricky thing around pain is that it can be associated certainly with actual tissue damage, but it also can be potential tissue damage. So pain is what a person says it is. We don't always have objective physical evidence of pain. Pain also is biopsychosocial, spiritual, and existential. So let me explain that. Bio means it is related to the body. So there you can see, for example, a broken bone. If someone has broken their arm, that is very easy to see. So that's bio. Psychosocial pain can be anything related to psychology or social, which is within your network. So let me explain. So with psychology, what you can do is have great amounts of pain related to, for example, losing your spouse. That would be a psychological. There isn't a physical. Your body hasn't experienced physical damage, but the pain that you experience is psychological, the loss and the great sadness and the emotional pain. That would be an example of psychological. Social, social, to stay with that same example of losing a spouse, that also can impact the social network that you have and the social support you have. Spiritual pain comes about when there is a crisis related to your beliefs. And so that can happen if you question anything related to a higher being or a higher power or anything related to that. So pain is, again, something that can be associated with tissue damage, but also not tissue damage. And it is whatever a person says it is, and it can relate to a number of different aspects. So, in summary, pain is always complex. It really is, because you have that context. You have the pain beliefs, the expectation. You have your cognitive set, which is pain catastrophizing is one example of that. It's, oh, I'm going to have a headache today because it's cold outside, and then it will be so much pain that I won't be able to go out. And just thinking about that is, okay, catastrophizing, making it much worse than maybe what it would be. Distraction. Distraction is a cognitive way that you can maybe manage the pain. If you start thinking about something else, that way you're distracting yourself from the pain. Attention can be both positive and negative when we're thinking about pain, because if you're focused on attending to the pain and focused on the pain, then that often makes the experience greater. But if you attend to, for example, the triggers, what causes your pain, then you might be able to say, I know that if I drink caffeine, which I'm enjoying doing right now, but for some people, caffeine is a trigger towards pain. Or there's other dietary things like eating fast food with a lot of dyes in that might trigger a pain crisis. Hypervigilance is when that's similar to attention, but it is even more, because what you become is hyper focused or hyper attentive to the pain. Going over to the other side, you see mood. You see catastrophizing is in the cognitive set. It is also in the mood set, because if you are thinking the worst about the pain, oh, I can't go for a walk today because that's going to cause pain. Um, Depression and anxiety also, we know, affect pain if you're anxious or depressed. And then we have the chemical and structure. And here what we have is the way that pain is passed through the body. So you can see also the nociceptive modulation. So that would go again with the structural. So all of this is to show how complex pain is, because you have the bio, and then you have the psychological here that you can see. That's all part of the pain experience within the person. Okay. So this is, I think, a good example of why chronic pain is such a challenging thing for us as clinicians to manage. Because when you look at everything that contributes to pain and everything that pain affects, it is all aspects of your life. It affects functional activities. It may affect the performance of activities of daily living, like being able to get out of bed, dress, walk. It certainly affects sleep. If you're having a great amount of pain, then having a good night of sleep is extremely challenging. It affects how you're able to work, your household activities. It affects leisure activities, whether or not you can go on vacation or whether or not you can enjoy doing other things. And certainly it affects your energy level. And then we look at the social consequences. If you have a lot of pain, often you're a little bit grouchy because you're not feeling very well. And so that affects your marital relations and your family relations because you're perhaps not as nice to your spouse and maybe you're a little snappy. It also affects intimacy, and because you're in pain, you're withdrawing from your social life. And so you really have more social isolation that happens. The socioeconomic consequences are that you're paying more for healthcare, so you have those healthcare costs. And sometimes when pain is severe, you end up going on disability. You're no longer able to work, and there's the lost productivity. So those are the socio as well as economic consequences. And then again, the emotional functioning, the irritableness, the angry, anxious, depressed. So you can see that there really is this multi-dimensional burden of chronic pain that affects just every aspect of a person's life. Now I'm going to just talk about the US, and this is just to give you an idea of how serious the problem is in the United States. So in the United States, we have 50 million adults who are affected by chronic pain. So it is one of our major chronic illnesses or chronic conditions that we're dealing with in the United States. Of that 50 million, half of them, or 25 million, report severe pain on a daily basis. Okay? So this is severe pain means that it is on a 0 to 10 scale. We're looking at 7, 8, 9, 10. That would be what's considered severe pain. And then 20 million have high impact chronic pain. So let me explain the difference a little bit between what is severe pain and what is high impact pain. Some people who say that they have a 7 on their pain scale can still, okay, even though I'm having a lot of pain, I'm still going to go to work. I'm still going to do these things. And they suffer through it. Okay. High impact chronic pain means that this person may still have a 7 on their scale, but their impact on their life is that they aren't able to go to work, that they aren't able to have good family relations, that they have a lot of anxiety. So the impact of the chronic pain, if you think about it and you go back to this biopsychosocial, a high impact means that these multidimensional areas are severely impacted by the pain. Okay, so severe pain is just how they're rating the pain on the 0 to 10 scale, but the impact is what impact it has on your life. And this is particularly a US problem. And you can see that I cut off this graph at 2018, and there's a reason for that. So let me explain what happened in the United States situation, again, focused on the United States. In the United States, and this is true only of the United States, this is an American, a US problem. What happened was the drug companies were really encouraging of prescribing opioids. And the reason this chart is cut off at 2018 is that's about when we figured out that in the United States, it was very embarrassing that we had more deaths in the United States related to opioids, the drugs, compared to car accidents. So in 2018, all of a sudden, that realization, if you look at that graph, you can see that top line there is because of drugs and opioids, and how much we had deaths. You can see over on the left side of the screen, this is deaths per 100,000. And you can see how much opioids were causing deaths in America. So because of that, what happened was that the Center for Disease Control, the CDC, showed that there were so many drug overdoses, and also that it increased by nearly 10% from 2006, and also that it was unequally distributed among the American population, with more effect of the Black population in the United States. So this was really a United States embarrassment, if I can say, is that we realized that we really had a big problem related to opioids. And so the CDC came out with a recommendation about non-pharmacy. Okay, don't use those opioids. Okay, please do not use those opioids. So non-opioids are preferred for chronic pain. And so at that point, then what happened is that more research funding came about to try to look at ways to manage chronic pain that didn't include opioids. So that's a brief description of chronic pain in general. And then also, I needed to set up and explain and understand the US situation that leads to why this research was funded. Okay, so chronic pain is a big problem. Opioids is a really big problem at that time. Now we're a little bit better, well, quite a bit better, really. But the focus really on non-pharmacy, non-opioids. Now what I'm going to do is switch, and we're going to talk about the second learning goal for this talk this afternoon. And what I wanted to do is talk about the key characteristics of a pragmatic clinical trial. So this again is a little bit of background information that is a little bit more focused on research. So I'm going to just set the stage, because the research example that I'm going to share with you is a pragmatic clinical trial design. So why are pragmatic clinical trials important? Well, we realized as nurses that we aren't reaching patients with complex comorbid problems and those most in need. So when you think about how I described chronic pain is always complex. Okay? And we aren't reaching complex patients. The next point here in the middle is traditional research rarely happens in typical clinical settings. This means, like a randomized clinical trial, we may recruit from the hospital, but it's not usually part of normal clinical practice. It's outside or in addition to normal clinical practice. That would be a randomized clinical trial. The challenge with that is that findings then are often not feasible for real world uptake. Okay, they're not practical and we can't really use them in a regular clinical setting. The third point you can see here is that we aren't asking questions important to providers, patients, administrators, or policymakers. So these are the challenges of what's going on right now. We aren't reaching patients that are complex. Traditional research rarely happens within a normal clinic flow, and we aren't asking questions important to our stakeholders. So, in summary, randomized clinical trials or efficacy research is not often relevant to clinical practice because traditional randomized clinical trials study the effect of a treatment, but it's delivered to carefully selected populations under ideal conditions. And this makes it really, really difficult to translate results to the real world. And this is why I think pragmatic clinical trials are really important for nurses to do. Because if we as nurses want more evidence-based practice, a clinical trial, well, there our goal is to improve practice and improve and inform clinical and policy decisions. Taking a look at the design with a randomized clinical trial, it tests the intervention against placebo usually, or usual care, using rigid study protocols with minimal variation. Let's look at a pragmatic clinical trial. It looks at real-world treatments using flexible protocols and local customization. Again, exactly what we normally see in the clinical situation. Okay? The participants for a randomized clinical trial is highly defined and carefully selected. We have our inclusion criteria, we have our exclusion criteria, and we follow that. That's a randomized clinical trial. Look at the pragmatic clinical trial. Criteria is less strict. Think of who comes to your clinic. It's a lot of different patients. Okay. Well, if we want to say that this intervention works in a regular clinic, we have to take everybody who comes to the clinic and not some very rigidly defined inclusion and exclusion criteria. So if you look at the measures, okay, for a randomized clinical trial, usually it requires data collection outside of normal routine care. You carefully select your measures that are going to have hopefully show a difference or an effect, which is what a randomized clinical trial is all about. Okay. However, the measures in a pragmatic clinical trial are usually quite brief if you're administering any measures at all, or they're coming from the electronic healthcare record or some other thing that's already regularly used in clinical practice, so that data can be easily collected in clinical settings and you're not doing more things outside of regular clinical setting. With a randomized clinical trial, it's rarely relevant to everyday practice. But with a pragmatic clinical trial, It's very useful in everyday practice and especially in clinical decision making. So, in summary, I'm saying that we as nurses really need to start thinking about moving past the randomized clinical trial and doing more pragmatic clinical trials. Now, today, what I'm going to do is talk a little bit about one type of pragmatic clinical trial. And this is a SMART design study. Okay. And SMART stands for sequential multiple assignment randomized trial. That's a lot of words and it takes a long time to say. So we just say SMART. And what it does is it examines the best sequence of interventions. What it does is it randomly assigns your participants or patients to each stage of treatment, and then it allows for modification to treatment based on their response. And this is exactly what we do in clinical practice because we make treatment decisions, or at least I hope all of you make treatment decisions, and I'm sure you're all good nurses, so you do this, based on how your patient is doing. That's what we do. So the reason I like this is that it really is very much like what I do in clinical practice. So here is what a smart design looks at like. And I'll walk you through what normally happens for me in my clinic when I see a chronic pain patient. The chronic pain patient comes in, and the first thing we do is cognitive behavioral for chronic pain for 6 weeks, because we know that if we retrain the brain, okay, then they're going to be better able to manage their pain and also deal with the other interventions that we're doing, okay? Because if you remember back to the introduction of what pain is, the psychological component is a big part. So if we start with cognitive behavioral therapy and retrain the brain, then we have less pain catastrophizing. Oh, I can't do this. This PTOT is physical therapy, occupational therapy is too hard. It'll hurt too much. I can't do it. Okay. We have found that if we focus on retraining the brain first, that we're much better with our physical interventions. Okay. After everybody gets the cognitive behavioral therapy, then I meet with them and we see how they're doing. And if they tell me, you know what? I'm doing pretty good. My pain is a 4. I say, hallelujah. Keep doing what you're doing. Okay. If they say their pain is moderate or high, then I say, I think we better try something else. And if you look here, CIH means um, complementary and integrative health. Okay, so this is chiropractic, yoga, acupuncture, massage. So these are all complementary modalities. So I say to them, well, you know what? For some of my patients, I have found that, having their spine realigned if they have lower back pain, so going to a chiropractor, having therapeutic massage works pretty good. Would you like to try that? And if they say yes, I say, okay, great. I want you to try that. And you can see stage 1 here is 3 weeks. So I say, okay, I want you to try this for 3 weeks, and then I want you to come back. And we're going to check in and see how you're doing. Well, when they come back, what's the first thing you do as a nurse? You do a nursing assessment. How is your pain? on a scale of 0 to 10. How are you doing? Well, if they say, well, my pain went from a 7 down to a 4, I say, hallelujah, keep doing what you're doing. And so look at that. If there's an early response and the answer is yes, okay, then we continue with CIH. If, however, they say, I'm still at a 7, or if they say, my pain has gone up to an 8, 9, or 10, okay? So if they're the same, unchanged, or if they've gotten worse, then we re-randomize, okay? Just like in clinical practice, we say, oh, well, this didn't work. We need to try something else. And so then what we did is we switched to either SRC, which is conventional or standard rehabilitation therapies, which is physical therapy and occupational therapy. Or what we did was we continued with CIH, which is the complementary integrated health, as well as added on the physical and occupational therapies. So you can see that this design, the SMART design, is exactly what I do in clinical practice. So it's very, very pragmatic because it is exactly what we do in clinical practice. And forgive me, this mouse has a little bit of a mind of its own. So another way to call this is that it's an adaptive design. Okay, is another way to call it. Because we are changing or adapting our intervention based on the patient response. Okay, so with that introduction of what is a pragmatic clinical trial and what is a SMART design, now I'm going to give you a little bit more about the research study that we did, and I just kind of showed you a little bit of what we did. So the learning goal here now is to describe a pragmatic clinical trial. And that's based off what I'm going to be sharing with you, which is this example. So a little bit of background is that physical and occupational therapies are really standard rehabilitative care for chronic pain. Especially because lower back pain is one of the most common musculoskeletal chronic pains that we deal with. A growing body of evidence supports complementary and integrative health therapies such as acupuncture, chiropractic, yoga, and massage. However, very few studies have explored what is the optimal duration, sequence, and combination of these two therapies to manage chronic pain. So you can see that this question is very, very clinically relevant. Okay, so it isn't it. So the question for a pragmatic trial is a little bit different, again, because we're not asking, does this intervention work? But we're looking at what in clinical practice happens and how can we inform the best clinical practice possible using these therapies. Okay, so I'm just going to talk about our primary aim here. And our primary aim is to determine the best sequence of therapies. And our primary question was, is it better in clinic to start with regular PT, OT, physical therapy and occupational therapy? Or is it better to start with complementary and integrative health modalities? So this is our primary aim that we're talking about. And our participants were adults with chronic pain that had been referred to the Interdisciplinary Pain Management Center. So let me explain a little bit. Is that number one, these are people with chronic pain. And the definition for chronic pain is someone who has pain for more than 3 months. Okay. Also, if they're being referred to an interdisciplinary pain management center, they're past the level of primary care. So they're past the level of what a normal physician or nurse practitioner would manage in a regular clinic. And they have been referred to further care, which is in the interdisciplinary pain management center. So in summary, these are difficult patients. Okay, they've had this problem for a long time, and in the regular clinical setting, they haven't been able to manage it. And so they say, please take over. We need you to deal with these patients for us. Okay, now I wanted to show you that with pragmatic clinical trials, okay, what inclusion and exclusion looks like. Okay, because remember when I talked about randomized clinical trials and pragmatic clinical trials, I said a randomized clinical trial usually has a lot more inclusion exclusion criteria. So let's look at what the inclusion criteria is. Basically, it's if they have chronic pain. That's it. Very simple. If they have chronic pain. Is it longer than 3 months in duration? That makes it chronic. And then also if they have pain interference or physical function or 7-day average pain intensity of 3 or more. So basically, if they have pain, that's it for the inclusion criteria. They have to have pain and it has to be chronic. Exclusion. Well, because of what we were doing, if they were having prior or upcoming surgeries, then we wouldn't be able to do a lot of our interventions. So we did have to exclude for that. We also had to exclude for unstable psychological disorders, i.e., if they were really serious. Again, if it was, stable, if we were managing them on medication or, or if they were able to function in daily life, then, that was fine. But if it was a schizophrenic break or something like that, really serious, bipolar disorder that was really not managed, then, they wouldn't be able to participate to be able to get an effect. The other thing that we wanted to do is, as I talked about opioids, we know that we have a lot of problems with substance use disorder, which is the use of medications outside what is normally prescribed. That would be a substance use disorder. They're either taking prescription medications more than prescribed, or maybe they're going out and buying illegal drugs. So anyone with substance use disorder, we excluded because that's very difficult to be able to number one manage, but also to be able to have real good evidence coming from the trial. But the reason I'm sharing this with you is that it really is quite brief for our inclusion pain and our exclusion. There isn't a whole lot really that we're excluding. Yeah. Okay. So here we go. And I kind of walked you through a little bit of this before when I was describing what the SMART design is. So the pre-enrollment measures. The reason this is a pragmatic clinical trial is this is exactly what we do in normal clinical practice. So it was nothing new. So when someone comes to our pain clinic, we say, we want to know about your pain. We want to know how the pain is affecting your life. So we didn't add any other measures than what we normally collect when they come to clinical practice. Okay, so pre-enrollment measures. Okay, then you can see here, stage 1 is where they're randomized to either CIH or SRC. And again, this is if they're experience moderate to severe pain after the CBT, the cognitive behavioral therapy. Stage 2 is the adaptive stage. This is where we've assessed them. We said, how are you doing? And they're saying, yeah, still having pain. And so we adapt and re-randomize them. Stage 3 is where we look at how are they doing over time. And this is important because with a randomized clinical trial, often what happens is that you have a follow-up. Okay, so your intervention for us was 6 weeks. So with a randomized clinical trial, you have your intervention for 6 weeks, and then maybe you do another assessment at 12 weeks. Okay, and that's considered the follow-up. But you don't continue to provide intervention between when you stop the intervention at 6 weeks and when you do your follow-up measure for a randomized clinical trial. With a pragmatic clinical trial, because we're doing real life clinical experience, you can see that we aren't saying to the patient, no, okay, you don't get anything else. There's optional additional CIH, okay, the complementary and integrative health therapies, or standard rehabilitative care based on how they're doing. So again, very much like clinical practice, we continue to work with the patient and we continue to give care. Okay, so again, this is much more closely related to what you do in regular clinical care. So stage 3, we called it optional, okay? Because based on your clinical judgment as an advanced practice nurse, you are going to then modify what they're receiving for care. Okay. And then what we did is that we continued to follow up with them 3 months after they received their care and 6 months after their care. Because again, with regular clinical care, you have regular check-ins. Okay, how are you doing? But remember, again, with every check-in, you're using your clinical judgment and saying, well, maybe we should tweak this a little bit. Maybe we should give you more of this and that sort of thing. So it's an ongoing relationship of care. Now I'm going to talk a little bit about our main outcome. And this is what's called a pain impact score. And the reason I like it is that it certainly does the pain intensity, which is that 0 to 10 scale. But as you heard when I introduced what pain is, there is a lot more than just 0 to 10. So this takes a look at that pain interference or how pain impacts all the different dimensions of your life. And it also specifically looks at physical function, how pain impacts physical function. So it's a composite measure. So it isn't just one measure, but it's these three things coming together that gives us a better overall picture of the whole pain experience, which is the complex pain. So just one measure really, I would say, isn't enough when we're looking at pain. So, and don't worry about remembering this, but I did have to put a little bit of statistics in just to share how we did it. But don't worry about this, learning this at all. But what we did was a general linear model regression. And so we're regressing the pain impact score on stage one treatment arm. And then we control for the baseline impact score because that could be all over the place. So we want to control for that. And then it's a repeated measures. So repeated for each time point, end of stage one, end of stage two, 3-month follow-up, and 6-month follow-up. So that's what we did. Okay, so now let's take a look at the results. And the first thing I want you to see is that there's a lot of NS, which means not significant. So you're going, why are you showing this? Not significant is not good. Well, in this case, it is. Because remember, at the beginning, you want to take a look at your two groups. Okay. And our two groups are those receiving complementary and integrative health, and those receiving physical therapy and occupational therapy. And you don't want them to be different. Okay. You want similar patients in each group so that when there is a change at the end, you know it's because of the intervention and not because they were different at the beginning. So, what you want to see and what you always want to do with any trial where you're doing an intervention is take a look at your groups at baseline or at the beginning and make sure that you have a whole lot of not significant. And at that point, that's the one time you go, woohoo, when you see a not significant. If you're at the end of the trial and see a lot of not significance, you're going, oh, that's horrible. But I'm also showing you this so you can see kind of what we kind of took a look at, and who our population is. Most of our population was male, okay? An average of 76% male. And this is not surprising when we think of chronic low back pain because men are usually doing much more physical activity and physical labor, and so they're more likely to suffer. Although after having lifted my boys as they got bigger and bigger, I think that more mothers probably have chronic low back pain as well. Also, if you look here, this is a relatively young population in general. We're looking at about 40 to 45% being 25 to 34 years old. And then another 35% of the population being 35 to 44. And the reason I'm pointing this out is that this is prime key working age. Okay, so we're looking at males of working age. And that's why this is especially important for us to look at because the number one reason for disability in the United States is chronic pain. So if we can learn how to better manage chronic pain, then America will do better because we're keeping people in the workforce and productive for many more years. So most of them were married. Most of them had some college or had finished college. And as I explained before, most of them had musculoskeletal pain. We didn't have a whole lot related to neuropathic pain. 88% was musculoskeletal pain, which is, again, normal. Our average pain intensity was between 4 and 6, which is moderate. The pain interference was moderate. Physical function impairment was moderate. And that's, remember, if you looked at our inclusion criteria, we were hoping to see that they were having this pain right now as well as chronic pain. So this is exactly what we would expect. Anxiety. Most of the, well, not most, I have to say. It was about equally distributed. The 37 and 32%, really, that isn't too much difference. Between W and L is within normal limits, but that was too much to type out. So that's why I have it abbreviated there, within normal limits, and then moderate. Depression, again, you see within normal limits was about 40%, and then moderate depression was about 25%. Anger within normal limits was about 45%, and then moderate was about 25%. And again, this is part of our normal assessment process when people come into the clinic, because what we're looking at is the whole complex picture of pain. Sleep-related impairment. We had about 40%, between 40 and 45%, saying they had moderate sleep impairment, and between 15 and about 20% saying they had severe sleep impairment. Fatigue, you can see mild there is about 22%, and severe fatigue is about 40%. And then we also looked, again, thinking of pain being the whole picture, we looked at the satisfaction with social roles and activities, because social is also a part of the pain experience. And so here what we looked at is we looked at average satisfaction and moderate dissatisfaction, not so happy with social roles and activities. And it was about equally distributed between those two. So again, that was our normal intake. But again, remember, this is an interdisciplinary pain clinic. So we're doing probably a little bit more of an assessment of the pain experience, because these are people who have failed, if I can use that word, primary care, and needed to be referred out for more specialty care. So here we go. And this is our major question. So our major question is it better to start with standard rehabilitative care, or is it better to start with complementary and integrative health? So you can see where the circles are. So we're comparing that to that. Okay, that's our main question here. And here's the answer. So at the beginning, and this is looking at pain impact score, that our composite measure. So at the beginning, you can see, let's see. Okay, let me just walk through it first so you get an idea of what we're looking at. So can you see my arrow? A little bit. Okay, good. So let me try this. Okay, the group who started with standard rehabilitative care, okay, is these blue. Okay, so these are standard rehabilitative care, is the blue. The group who started with complementary and integrated health is the orange. Okay? Now, let's look at the lines. The line is the mean of the group who started standard rehabilitative care over time. Okay, looking at these numbers. And the group who started with CIH or complementary integrative health is this orange line. Okay, so just explaining a little bit how to take a look at this chart. And then you can see stage 1, stage 2, 3, and 6 month follow-ups. So you can see over time. Okay, first of all, baseline. There was no significant difference. Yay! That's exactly what we wanted to see. Then what we want to do is we want to take a look at, okay, who improved? And what we can see here is that the group who started with complementary and integrative health went from 29.8, so basically 30, down to 26. And those who started with PTOT went from 30 down to about the same, 29. Okay. So then when you look further out, what you can see is after that first time point, they really are about the same. Okay. There's really no significant difference between the groups anymore when you get to 6 weeks, 3 months, and 6 months. So when we look at this first stage 1, statistically, the difference between the two is that it was statistically significant between the two groups. So the complementary and integrative health did better than the standard rehabilitative care. And if you look further on, you can see no significance after that first initial stage 1. Now I wanted to show you a little bit more, and hopefully on Zoom you can see this maybe a little bit better than in the room, because from here it looks pretty small. So I'll just walk you through. I wanted to show you a little bit some of our secondary outcomes. What we found was that pain intensity, pain interference, fatigue, satisfaction with social roles, physical function improved more in the complementary and integrative health group than with standard rehabilitative care during stage 1. Satisfaction with social roles remains statistically significantly better in the complementary and integrative health group, even at 6 months. So, conclusions and limitations. So, what we know here is clinicians can feel confident recommending patients start with complementary and integrative health therapies if that is their preference. And findings led support to expanding access to complementary and integrative health approaches. So I'm going to pause here and see if you have any questions because we covered quite a bit of information here, but know that I do have another presentation. But we could stick with this as well. Um, because we're together until 4 o'clock, right? Okay, yeah, we have plenty of time then. So, any questions about number one, general pain, number two, pragmatic clinical trials, and number three, this example of a pragmatic clinical trial? Yeah.
That was a good presentation that we can have an experience. So I have some questions
Mhm.
that I asked from your experience because I know that the first enrollment you do the randomized control trial.
Yep.
And so shall we match something? I know that this one is a low back pain,
Correct.
but I think about if we do something with the cancer patient,
Correct.
shall we matching?
No,
No.
not if it's pragmatic.
Ah,
So let me explain why we match. Okay. We match because there are significant variables that we know will cause a difference. Now, theoretically, randomization means that you are going to have similar groups. Okay. Theoretically, in reality, that doesn't always happen unless you have a very, very large group. And so we match to make sure that we control for important variables that might be different. And that's why we match. So we know for cancer, and I'm an oncology nurse, so I'm that certainly gender makes a difference, age makes a difference. So those are two of the common variables that we sometimes match on. If we're looking stage, yep, that's another common one that we match on as well. Stage, because 1, 2 stage cancer is much different than 3, 4. Yeah, that sort of thing. And also sometimes we match if we're not doing just like one type of cancer, breast cancer, we would match on type of cancer. Like if we're doing solid tumor cancers, we'll match on breast, prostate, lung sort of thing. Or we'll match on solid tumor versus hematological, the blood cancers, the leukemias and lymphomas and that sort of thing. So, yeah.
thank you. And the second
Yeah.
question, because I know that when we do integrative therapy,
Yeah.
when we enroll them,
Yes.
sometimes we tell that, okay, after we do some technique or strategy, and so you're going to start with complementary therapy first. Most of people, they need something like the modern style medical, and they said, oh, can I drop out? Or sometimes they did like 3 weeks, but just 1 week or 2 week, and they said like, I don't feel it's better. Shall I drop? How you handle with this situation?
Yeah, thank you very much. So what I do is I say, you know what? I maybe if you're not feeling an effect yet in 2 weeks, that you haven't done it quite long enough. So, and in our case, and again, this is the American situation, is that we say we really, really want to manage your pain without the use of opioids. And so if you can help us, learn a little bit more about that and make sure that we're managing your pain without opioids, then you'll have a better quality of life. So those are some of the things that I talk to the patient about to encourage them to continue. Yeah. But it doesn't know. Sometimes they drop out. I mean, that's also true. Yeah, very definitely. But we use motivational interviewing to try to, encourage and keep the participants in the study. Yeah. Hmm. Yeah.
So any questions from the online? You can send your questions via chat, or you can turn on your microphone and you can ask some questions. I think that we have some uh, doctoral students, I think that this design, I think it's very good design, although we are not familiar with this design before, but I think that it's in terms of practical, it's maybe flexible than randomized control trial. So any questions? Okay. I have one questions about the result
Yeah.
of your study. You mentioned that at the 3 weeks, um, 3 weeks measurements, it's difference between the two group. But in the follow-up at the 3rd month and 6th month, it seemed that two group did not difference in terms of, so what should be the explanations of why it did not significance, but at the first it's significant difference in terms of the outcome?
Perfect. Thank you. Can we just do full screen rather than? There we go. But that's not showing that. Well, now it did. Yay! Thank you. I'm needing technical support to get the next PowerPoint up. So thank you. Uh, we attributed it to, from our clinical experience, is that physical therapy and occupational therapy take a lot longer for patients to get a benefit. And so what we were able to demonstrate with this and having them not be different later on is fine, because that shows us that, physical therapy and occupational therapy also are good. They just take a little longer to kick in. And again, this is a little bit different than a randomized clinical trial because we aren't comparing to usual care or placebo. What we're doing is what we normally do in clinical practice, which is we have a number of different interventions, and we're never saying to a patient, "Oh, we're not doing anything for you, go home." That's not normal clinical care. We're doing something. So this was looking at, again, our main question was, which is better to start with, complementary and integrative health or occupational and physical health? So in the end, we were able to show that both of those will get to better pain management, actually as good or better than opioids. Okay, I didn't show that with this, but that is one of the conclusions we had. But if we want to have a more quick or fast effect for the patient, then starting with complementary and integrative health is better. Yeah, thanks for asking. Yeah,
I have the questions about the two group enrollments.
yeah.
Did they know about the two options before enrollment or just randomized?
Yeah, they did.
They did,
They
right?
did know about it. And so again, this is like using motivational interviewing, because sometimes if they randomize and they go, "I didn't want that one, I wanted that one," a sort of thing. So with clinical practice as well, sometimes what you recommend isn't what the patient wants. Okay. And so then you use your motivational interviewing in regular clinical practice. Well, I really think this is going to help you, and then you work through that with the patient. So that's, yeah. So we did do randomization, and the patients knew that they, because of informed consent, they knew that we were randomizing. But what we said was, our question here is we don't know, which is our aim. So the question for the patients, we said, we don't know which is better for you, complementary or integrative health or physical therapy and occupational therapy. We don't know which is better to start with. So what we have found is that some patients, okay, do better with complementary and integrative health. So we're starting you with that. Okay. And then if for the other group, we say, well, some patients do better with physical therapy and occupational therapy. So we're starting you with that.
And another question, please, is about randomized control trial. As
Yeah.
we try to separate between two groups because of we avoid confounding factors.
Correct.
But if it's, I don't know, it's about pragmatic clinical trial. If the weighting and the talk is about effectiveness,
Correct.
can considers be confounding factors, or we just like report like in the clinical reality?
Yeah. For pragmatic clinical trials, we aren't as concerned about confounding. For this study, we didn't have to worry about confounding because, quite honestly, they would have to go outside the clinic and get, chiropractic care or acupuncture or physical therapy or occupational therapy. And the likelihood of them going out and getting that sort of care outside of our clinic was very small. It would have been a little bit different if we were doing talking about sleep hygiene, maybe would be an example. And then the other patient talked to them and said, well, are you doing anything about sleep hygiene? I was told to do this, 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 this. Well, that's definitely confounding because, the patients in the waiting room are talking and sharing that information. But again, with a pragmatic clinical trial, we are less concerned about that because if it's part of normal practice and part of real life, that goes on. And the way I write this in the grant, okay, is in the limitations section, I say confounding, if it was like sleep hygiene, I'll just stay with that example. If the patients talk to each other, okay, and share that information, what happens is that the control group, now I'm talking about randomized clinical trial, the control group then would get better, okay, with what we're trying to measure. That moves then the randomized clinical trial closer to a null hypothesis, i.e., there is no difference between the groups. So if we show a difference between the groups and there has been confounding, that just means that we have an extra better special intervention that has more effect than what we would expect. So that's the way I handle it in a grant application. Yeah.
I have some questions about the adherence to the interventions.
Yeah.
How do we know or how we monitor for the participant to adhere for the interventions?
Thank you for that. For this study, again, it was very easy because they were coming to clinic. Yeah. So all the interventions were provided by clinic. There's other ways that we look at, and I don't like the word adherence. So I'm going to change and encourage you to think about engagement. Okay. So using the word engagement, how engaged the patients were with the intervention. So with a web-based intervention, again, it's really easy because you can monitor the computer activity, and so on. With a pragmatic trial, we still want to kind of look at engagement because we want to be able to look at dose of the intervention. If they come to 3 sessions or 6 sessions, does that make a difference? So we look at, the dose of the intervention. But for a pragmatic clinical trial, we aren't as concerned about engagement because, again, it's real world. Some people are going to be more or less engaged. With a randomized clinical trial, we are much more concerned with engagement. And the reason being is that the question is different. The question again is, does this intervention have an effect Okay. And if they don't show up and they don't engage with the intervention, you're not answering your question of whether or not this intervention has an effect. So we're much more concerned with randomized clinical trials in relation to engagement. Yeah, good questions. Yeah.
In terms of complementary integrative cares, you
Yeah.
mentioned is about to make massage, yoga, and chiropractic.
Yeah.
So I think is if the one who provide like nurse or specialist who provide care is they know is about during the research project or the quality, because I'm just thinking is about it can be biased if they not by the care providers.
Correct.
I'm just thinking is about how about doses, quality, consistency in between one intervention or one-time interventions.
Yeah.
Thank you.
Yeah. How to answer that? Yes, the simple answer is yes. You have to be concerned about that. But I think, yeah, correct. Yeah, I think you answered your own question. Correct.
Kind of like that. Is in between quasi-experimental research.
Maybe that's a good way to think about it. Yeah, thanks for bringing that up. Yeah. 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 Good.
Can I share some ideas about the intervention? If we use the terms of interventions fidelity, can it answer these questions? Like I know that the intervener, they have trains already, and they know that
Right.
the one sessions, it should be like 30 minutes or 40 minutes.
Correct.
And then how often they did.
Correct.
Right. Can we use the intervention fidelity? Because it's gonna be like dose, duration, enactment, or whatever that they put it.
Yeah, that's one way to look at it. Thank you. Yeah. Well, it is now 3:00. Do we want to take a brief stretch break before I start in? Or do we want to keep going?
5 minutes.
5 minutes?
5 minutes.
Okay.
Yeah, 5 minutes. 5-minute break. Because another topic is about the management.
Yeah.
So I think it's also very interesting. Okay.
But
so 5-minute breaks.
I will go a little bit more quickly through this because I think this is somewhat basic, but it's related to pain management that maybe most people will be somewhat aware with. Whereas the last presentation was a lot of new information. So I wanted to, take the time and go carefully through that. So let me stop talking because 5 minutes just became 4 minutes. welcome back. Okay, so what we're going to do here is we're going to talk a little bit about the etiology and types of pain. We're going to talk about a pain assessment, the goals of pain management. We're going to identify universal precautions and universal screenings. And again, this is for opioid screening. So this is again coming from the US context. So I'll go through that maybe a little bit more quickly because you don't have to worry about that so much here in Thailand. Describe the barriers to pain relief and discuss issues regarding constipation. Because when we're talking about pain management, we're usually giving pain medications, and with pain medications come constipation. So you can't talk about one without the other. Not if you're a good nurse, is my argument. So here you go. What is pain? We talked about this before. It is complex. It is what a person says it is. Now we're going to talk a little bit about etiology or the causes of pain, and I'm going to stick with examples in oncology. So for oncology, there can be mid-thoracic pain from pancreas cancer, arm pain from if there's metastases to the bone and you have a fracture, you have cancer treatment, you have, horrible mouth, oral mucosis that you have to worry about. You have peripheral neuropathy related to the chemotherapy, and then you have unrelated. So in summary, with cancer, you have a number of different places or causes that pain can be coming from the cancer itself, from the treatment, and then pre-existing like chronic low pain, back pain from what we were just talking before. Let's talk about neuropathic pain. Our last presentation really focused, as you saw, on musculoskeletal pain. But now with oncology, neuropathic pain is something we have to deal with much more often, and often related to the treatment, from the chemotherapy-induced peripheral neuropathy. So with neuropathic pain, what we have is that there's the abnormal processing of pain signals and damage to the nerves. So it could be from the disease, it could be from injury, or for cancer, it's most often related to the treatment, the surgery, radiation, most often chemotherapy. Okay. There's 3 different categories of neuropathic pain. Number 1 is the continuous, and this is like a continual burning feeling. Or it almost feels bruised, like, the next one is shooting pain, okay? And the other thing is allodynia, where you have abnormal sensitivity, like even a very like a light touch like this, it's like, oh, it's really, really, really painful. So those are the 3 types of pain descriptors for neuropathic pain. Again, that burning pain, which is continuous, the shooting pain, or the hypersensitivity. So how do we treat this? It responds to antidepressants. So we look at the SNRIs or the TCAs. It also responds to anticonvulsants. The important thing to know is that opioids really don't work very well on neuropathic pain. So this is a little bit about neuropathic pain in oncology. And again, much more common with cancer. So let's talk now a little bit about pathophysiology of pain. If we're looking at somatic pain, that arises from bones, muscles, and connective tissues. And the quality is aching or throbbing or bruised. Here again, this responds to acetaminophen, NSAIDs, and opioids. Okay. Then we have the visceral pain, and that arises from organs. So you have your stomach, liver, bowel. And here the quality is different. You have that cramping, colic, squeezing. And this is often referred to another site. So it might be happening in one place, but they feel it in another place. That's called referred pain. Okay, and an example that I have here is gallbladder. Again, visceral pain is organs. The gallbladder pain may be perceived in the right shoulder. So, what you might be more familiar with for referred pain is like with a heart attack. Okay, a heart attack you often feel, in the arm. The same sort of thing happens with cancer, with the visceral pain. So here again, it responds to opioids, acetaminophen, NSAIDs. We also, for the visceral pain, do interventional blocks, okay, where we do a spinal block or a stent. So those are some ways to manage the visceral pain for cancer. Now let's talk a little bit about a pain assessment. Now this is an acute or basic pain assessment. This is a little bit different than what we talked about in the last presentation, which was a chronic pain assessment, okay? So this is acute basic pain assessment. So this is kind of nice because you can compare and contrast the two different assessments. You ask about location. Point to where it hurts. That's number one. Number two, quality. Okay. Is it aching, sharp, that sharp stabbing pain, or is it burning? Then you ask, okay, is it mild? Is it moderate? Or is it really severe? So you take a look at that. And then also you want to know about the duration, the frequency, okay, how often this happens, the timing, okay, is it short, like with an aching or a burning, it might be long, because that's more continuous. If it's sharp stabbing, and then the pattern, okay, I have my pain every morning when I wake up. I have it at night. I have it when I exercise too much. So those are the pattern questions that you want to get at. And then you also want to hear about the aggravating and the alleviating factors. And that kind of ties into the pattern, that I was just talking about. Okay. So an aggravating factor could be when you're lifting heavy things. That would aggravate the pain. Alleviating factors are equally as important. Okay. Well, I have a headache, but if I go into the bedroom, shut the door, put a cold washcloth on my forehead, lay down quietly, that makes it better. So as a nurse, we need to ask about both things. Okay, what makes it worse, but also what makes it better. And then associated symptoms. So even with the acute basic pain assessment, Okay, we don't go into as much detail as we do with a chronic pain, but we do ask about associated symptoms. For example, nausea or dizziness. We don't go into the complex assessment, but we do ask about other symptoms. Now, our first question that we ask when we kind of get an idea of how severe pain is rate your pain on a scale of 0 to 10. This is the most common question that we ask. 0 being no pain and 10 being the worst pain imaginable. Okay, and this gives us again, this is for acute basic pain. This gives us a really, really good idea of where we're sitting. Okay, you have to go past this, for the chronic pain, but for acute basic pain, this is the standard question. For descriptive, sometimes we say, is it none? Now, if they're talking to you as a nurse and we're talking pain, they aren't going to be saying none, but they could be saying it's mild or moderate or severe. And sometimes that's easier for patients than 0 to 10, because what does 0 mean? What does 10 mean? Even though you say 0 is no pain and 10 is the worst pain imaginable, what does a 5 mean? What does a 7 mean? For a patient, sometimes that's hard to explain or understand. So here's a little bit of one of the scales that we use, that we have at the bedside, that helps with a patient kind of understanding the 0 to 10 scale, because we use the blue moving to the red. Blue being pretty okay, red going, yeah, it's getting, it's getting worse. Please rate your pain. Okay. Now, because we realize that not everyone, the 0 to 10 scale doesn't work for everybody. Okay. And specifically pediatrics. Okay. The 0 to 10 just doesn't work for pediatrics. The FACES pain scale was developed to help when 0 to 10 is a little bit difficult to understand, and especially for pediatrics. So you can see the FACES scale here. And what you do is you show the FACES scale and you have the child point to which face best represents how they're feeling right now. So you can see that the first face here, it's like, oh, I'm okay. Not smiling, but okay. And then you can see on the far edge, where someone is really, really scrunched up and in a lot of pain. So here, what you can see is if they point at the first face, you score that a 0. The second face a 2, third 4, fifth. So you can see how this kind of, you can then turn it over to a number scale and match it that way. One of the reasons, I'll just share a little bit, that the FACES scale works actually in nonverbal patients is what we're able to do now with infants, and also with anyone who is not able to speak, i.e., for example, if they're on the vent in the ICU, or if they're have traumatic brain injury, or if they have dementia, Alzheimer's. Okay, we're able to take computer pictures of their face and be able to figure out their pain from that. So we're doing that now specifically in ICUs, and then also in with the babies or the infants. Some of the additional pain history that we want to look at is the medications that have been previously tried. And then these are specific to opioids. We want to make sure that we ask about allergies and ask about delirium. This is really important. Cultural factors that impact the pain experience. Okay? Because some cultures really value just not talking about pain, struggling and maintaining and keeping going no matter how much pain you're having. The other thing is the emotional aspects of pain are something that you need to, as a nurse, ask about for additional pain history. So what I want you to remember here is that pain is a sensation plus a reaction. So we need to think about, when we think about that reaction, what is the meaning of pain? So the meaning of pain is very different depending on your patient. So this is why, and this falls in actually with the cultural assessment, because this gets at some of the meaning of pain. If I have pain, I know I'm alive. This is morphine is just if you're dying. I don't want pain medicine. The pain is punishment from God for my sins. He's just self-medicating. Tell him to stop taking so much pain medicine. So these are all quotations that I've heard from patients or providers that ascribe meaning to the pain and pain medicines that you have to think about as a nurse when you're doing your assessment. The other thing is that I do want you to be a little careful about focusing on the number. Again, with a basic pain assessment or an acute pain assessment, we are just asking, 0 to 10. But they are, again, just that, one aspect or a unidimensional construct. So complaints of pain, as we talked about earlier, represent complex psychosocial constructs. So anxiety may mask pain and pain may mask anxiety. So keep your eyes and ears open, listen beyond the words that the patients are using, and if you're going past acute pain, complex pain assessments need to cover more than the pain intensity ratings. Because, as we talked about before, pain impacts all these dimensions of quality of life. So let's talk a little bit about our goals of pain management. Okay, we talked about the assessment, and now we're going to talk about the goals. First of all, our goal really is to optimize quality of life. I really should have put that as number one on this list. We want to provide adequate pain and symptom control. Now, I'm going to pause here a little bit and say this doesn't mean zero pain. Okay? Because it's unrealistic usually to get someone to zero pain. Adequate means that the pain is no longer impacting their life, that they're able to live the life close to the way they want it. Okay? We want to decrease distress caused by pain in the patient and family, provide an acceptable sense of control, relieve caregiver burden, strengthen relationships, and enhance meaning of life and illness. And this is important for us as nurses. We want to beware again of treating the number. Because pain intensity ratings are a unidimensional construct, we have to remember that complaints of pain may represent, I think I went back in my slides rather than forward. Yep. Okay. My apologies. Okay. Patient education. Yep. So what we want to talk about with the patient is that pain can be managed during oncology care. And that if we provide good pain control, we will improve that quality of life. And quite honestly, pain management may even, now we know, will extend life, because pain causes a great deal of stress on the body, which actually shortens life expectancy. So proactive pain education, for example, on constipation and other side effect management, is really important. And of course, we want to make sure that we give the patient permission to discuss concerns. Some of the things that we may want to talk about when we're providing the pain education is share a little bit about the effects of unresolved pain. If we have unresolved pain, i.e., if we don't treat the pain, often what happens is that they have more depression. And inadequate pain relief may hasten death by increasing, like I said, the stress on the body. That's number one. Decrease immunity. Okay, the IL-6 goes down, so they have decreased immunity. The physical function, that decreased mobility. Increased possibility of pneumonia and other issues, and certainly increased workload on the heart and lungs. So there's more wear and tear on the body. So clinical practice guidelines for quality oncology care, when we look at the issue of pain, what you will find is, number one, it recommends interdisciplinary care. Number two, assessment should be regular and ongoing. The pain level should be acceptable to the patient and the family. You need to document the response or not response, identify and address barriers, and then for controlled substances like opioids, you have to implement a risk management plan now. That's necessary now in the United States. Consider the culture, educate the family caregiver, address suffering. So this would be, suffering often relates to the psychological, the social, the spiritual, and refer providers to providers with specialized skill. So again, if you look at the clinical practice guidelines for oncology care under pain, this is what you're going to find. This is what we should be doing in oncology care. So our basic approach to cancer pain management is, number one, modify the source of the pain. So if they have a very big cancer mass, we want to treat that cancer mass because we want to modify the source of the pain because it might be pressing on something. If it's inflammation, we want to reduce the inflammation. If it's infection, we want to treat the infection. So again, we want to treat the source of the pain. Alter the central perception of the pain. And this we do through medications, through alternative strategies. Actually, as we talked about before, we're looking at PTOT, complementary and integrative health modalities, and we're trying to use those more and more over the pharmacology, which is the opioids. Then the third way for basic approach to cancer pain management is block the transmission of the pain. Okay, and here we're looking at the CNS, the central nervous system, and there we're doing blocks. Okay, so usually a spinal block or something like that. So those are the three basic approaches to cancer pain management. Okay, treat the source, alter the perception, and block the transmission. So what I like to do to remember some of this cancer pain management is the 5 A's. So you want to optimize analgesia, optimize activities of daily living, minimize adverse effects, avoid aberrant drug-taking behaviors, and improve affect is a way to think about the 5 A's of pain management. So now what I'm going to do is a brief overview of pain therapies in oncology. The first one is chemotherapy, radiation therapy, surgery, immune modulators. And the reason we're using these is all of them are to shrink the number of cancer cells. Okay, these are all therapies to do that. So you reduce the tumor burden in chemosensitive neoplasms, or with radiation therapy, we're hopefully reducing, for example, bone metastases to obtain some relief. So that's number one. Number two, we want to look at pharmacological therapies, and this is often opioids, but we also want to do non-opioids, analgesic, and neuromodulators. Number three, non-pharmacological therapies. So, and more, like we said, we're trying to have more non-pharmacological over pharmacological. So looking at massage, physical therapy, heat, cold packs, aromatherapy, distraction, and then again, the interventional approaches would be like the blocks. So when we think about the pharmacological management of pains, opioids are still the most powerful and effective drug. But we are much more aware of some of the side effects and the adverse effects of opioids. So if we can move past the opioids and manage with acetaminophen, NSAIDs, neuromodulators like antidepressants, the SNRIs, the TCAs, the anticonvulsants, the gabapentin, the pregabalin, and the anticonvulsants in particular, gabapentin is my go-to for neuropathic pain. Just to say that I'm prescribing gabapentin right away for neuropathic pain. And then other agents like topical agents. Some of my patients get really good effects from capsicum pepper, spreading that on the skin. We also, yeah. And then some of the other things that we do, you know, to for topical agents is well, that's the one I use most often. That's going to be complementary and integrative health, but then also muscle relaxants also helps because that relaxes the overall body. And often with pain, people are holding tension. So if you can relax the muscles a little bit, then you know the pain disappears as well. The interventional options for pain, again, are nerve blocks. Now, they are temporary. That's the issue with this. But the nerve blocks are a good thing to work with. I have had patients actually, usually the blocks last 1 month, 3 months, you know, and then we're maybe needing to do it again. But I've had some patients, you know, have a lot more long-term effects from the nerve blocks as well. And so some of the other things that what we want to do is we want to take a look at how we can manage some of the issues. Here, what we're doing is if there is specifically bone metastasis, which often happens with advanced cancer, then some of the things that we have then is the compression fractures. So what we do is inflate a small balloon to decompress the vertebrae. Or what we do is we inject, you know, some I call it cement here, but really it's really like cement, but basically we build up the vertebrae again so they don't rub and the pain isn't coming so much from the bone metastasis or the weakening of the bones. And then very rarely we look at lesioning of the nerves or some of the things like that, because that is a little bit more aggressive as far as treatment. So we usually that is a little bit rare. But these are some of the interventional options for pain that we commonly use. So when we look at the physical measures for pain, what we're looking at is some of the thermal, the hot or cold packs, physical therapy, positioning and bracing especially helps, massage therapy. And some of my patients really do well with TENS units, the electrical stimulation, nerve stimulation. So, but there again, the TENS units I find work better with my patients with musculoskeletal pain. And with oncology, we're often often experiencing more than neuropathic pain. And even though this is nerve stimulation, TENS I find doesn't work as well with some of the neuropathic pains as I thought it would. Lymphedema. Okay, if you're doing breast cancer, you're definitely working with lymphedema because lymphedema and breast cancer kind of go together a lot. So manual lymphatic drainage, compression sleeves, compression pumps help with lymphedema. Here we need to be a little careful with chiropractic, okay? With the musculoskeletal pain, like we talked about before, I use a chiropractor quite often. You saw that as one of my CIH therapy, my go-tos. But because we have to worry about metastasis to the bone, yeah, exactly. That's why we have to be a little bit more careful here. So we need to carefully monitor that for a physical measure for pain in cancer therapy. And then these are addressing the psychosocial spiritual needs with some of our complementary and integrative therapy. I find that guided relaxation often helps, guided imagery. I often use mindfulness-based stress reduction. Cognitive behavioral therapy. Actually, we know that cognitive behavioral therapy works just as well as opioids now. Your non-inferiority trial, that was one of the non-inferiority trials was cognitive behavioral therapy and opioids, and there was no significant difference between those two interventions. Spiritual support and prayer, support groups, music therapy, and quite honestly, laughing, humor therapy really helps with the psychosocial and spiritual needs that we need to think about with the cancer patient. And some of these other integrative therapies, like aromatherapy and acupuncture. Now, with acupuncture, we do have to, again, be a little bit cautious because of the chemotherapy. If their white blood cells are a little bit low, we can't even do acupressure because of the bruising. And acupuncture, because we're puncturing the skin with the needles, even though the needles are really small, like fine, like not even as much of one of my hairs. We still have to worry about, that if they're on chemotherapy, and we have to look at their blood counts. Some of the other things that might work is Reiki, therapeutic touch, or healing touch. So now I'm going to briefly go through universal precautions and screening. As I said in the beginning, this is really related to the US context, but I think it's also relevant a little bit here. So I'm going to just briefly talk about this a little bit. Okay. So when you're working in the emergency department, a patient comes in with blood on his face from a fist fight. Before you examine the wound, what do? You put on gloves. Exactly. That's right. Okay. That's universal precautions. Okay. You go to the airport to catch your flight to the US, which I hope all of you will do. Come visit me. Okay. You're well trained to pack liquids in 3-ounce containers, put them in a clear bag, wear slip-on shoes that are quick to remove and replace, arrive 3 hours early because universal screening. Everyone's going to go through screening. So really, that's what we need to do with opioid prescribing as well in oncology care. We cannot predict with certainty who will have problems. Okay? We just don't know. But by using universal precautions and universal screening, we can, number one, stratify the patient regarding their personal risk for opioid misuse, address the appropriateness for opioid therapy, determine the best setting and strategy for opioid prescribing. If we use regular use of universal precautions and universal screening in pain management, okay, really what we're doing is good nursing practice. And it will make your life a lot easier. So just make it a regular part, of what you do as a nurse. So for universal precautions in pain management, you want to make a diagnosis and identify treatable causes of pain. Perform a psychological evaluation, including the assessment for addictive disorders. Discuss urine drug testing with all patients. That's the universal screening. Just say, we're going to be doing this to everybody. And then they won't have to say, why are you doing that to me? Sort of thing. Informed consent, discuss the benefits and risks of opioid therapy and alternative therapies. And by doing that, certainly encourage, the alternative therapies. And what I do is I always do a patient and me, the provider, treatment agreement. So I review the expectations and obligations of both me and the patient. Okay. So I say, okay, I'm going to be giving you opioids, and I've discussed the risks and benefits. So you as a patient, I expect you to, and set that out. And then I emphasize that opioid therapy is a therapeutic trial. We want to have a rational plan for the use of them, perform regular reassessment of pain and function, regular assess those 5 A's that I talked about of pain medicine, and periodically review the diagnosis, comorbid conditions, and addictive disorders. And documentation is essential of initial and ongoing assessment. So that was kind of a brief review of universal, just talking about opioids and how to manage that, because we do use opioids more commonly in oncology patients. So it is something that, we need to keep aware of and keep on top of. So let's talk a little bit about the barriers to pain relief. For adequate pain management, it is important to anticipate and explore barriers that arise. And barriers arise at all levels. Number one, they might arise at the professional level with your colleagues, and then they might arise with the patient and the family. With professionals, with your colleagues, inadequate training in pain assessment and management, especially at end of life, is quite common, honestly. Concern for medication side effects, fear of addicting the patient, and concerns that opioids might hasten death. For the patient and the family, some of the common concerns are fear of addiction, reluctance to report pain because you want to be a good patient and not bother or distract the healthcare provider. Concern for adverse effects of pain medications, constipation, sedation, cognitive changes, and fear of becoming immune or building up the tolerance to opioids. So I'm going to conclude today with this talk with constipation. And the reason I am concluding this is because pain medications and managing pain and constipation go hand in hand. So we as nurses, especially with dealing with oncology patients who are receiving pain medication, need to be concerned with constipation. So Dame Cicely Saunders, the founder of the modern hospice movement, says we have to concern ourselves with the quality of life as well as the length. And if we're worried about quality of life, nothing matters more than the bowels. So the definition of constipation is infrequent passage of stool. and it is really common in cancer care. Only 10% of the general population have constipation, but 50 to 80% of cancer patients have constipation. And the reason we as nurses have to be especially vigilant and concerned about constipation is that it's not something you want to discuss usually as a patient. So it's really up to us as nurses to bring it up and make the discussion. The goal is to have a bowel movement every day or every other day. Now, everybody is a little bit different, so, kind of ask the patient and assess what is their norm. You want a stool that is soft, formed, easy to pass without straining. In oncology, one of the reasons why we have so much constipation is that we often have obstruction with some of the tumors, especially if there's a GI, ovarian, or bulky tumors. The lifestyle is affected when you have cancer. You're more likely to be inactive, decrease food and fluid intake. Sometimes you have hypercalcemia, hypokalemia, surgery, if there's been surgery especially in the abdomen area or anywhere along the track, then sometimes there's surgical adhesions. We talked about the spinal cord compression that often happens with bone metastases, and there's also other conditions that happens. And then drugs, which we have talked about. So in summary, there is a lot of good reasons why the rates of constipation are so high in our cancer patients and why we have to be, attending to this. So as I said before, what you want to do is find out what their normal history is, because if they say I've been constipated all my life, okay, then you know that they have a tendency for it. So that's number one. When you do your assessment, find out what's normal for them. Number two, you want to do your abdominal assessment. You want to listen for your bowel sounds. You want to press for tenderness, and you want to take a look at whether or not they're distended, whether or not when you percuss, whether or not you have tympany. You also want to do your rectal exam. What you want to do is assess for the presence and the character of stool in the vault. However, you have to avoid a rectal exam if they're take a look at their blood counts again before you do that. And then you definitely want to do a medication review when you do your assessment, and you want to rule out bowel obstruction before starting your treatment. Okay. What we're doing now, quite honestly, in my clinic, in my oncology clinic, is we're using handheld ultrasound. And we're doing that to just take a look for an obstruction, because then we don't have to send them for an x-ray. Okay, so we have just little ultrasounds that we now use to take a look for bowel obstruction. And then for diarrhea, okay, consider overflow diarrhea, which means that there is a bowel obstruction or a hard piece of stool and the diarrhea is going around it. That's the overflow diarrhea, because that often happens with oncology patients. So if there is stool in the vault, what you want to do is take it out. If it's a hard stool impaction, you can soften with an oil retention enema. You can also use a suppository, and we really, really don't want to get here. So we want aggressive prevention is needed to avoid impaction, because we really, really, really want to avoid impaction if we can. But if you have it, then these are the things that you need to do. What you want to do is, again, avoid the impaction. So some of the things that you want to think about is ask them to have dietary changes. Ask the patient whether or not they can increase their fluid intake. Exercise, even a little bit, will help. And then if you need to, use medications and sometimes other approaches, for example, an abdominal massage, to kind of move it along. Yeah, it works quite well. But again, if you have abdominal tumors, you can't do that. So this overflow diarrhea that I talked about is when there is a partial bowel obstruction. And so this is when you have to worry then about if, and how you clue into this is if a patient previously is constipated suddenly develops diarrhea, then you kind of get a hint, there's probably something else going on here. So an important part of managing constipation is definitely your patient education. So you want to tell your patient, okay, as soon as you go on pain meds, you have to have a bowel program. And the bowel program must be used regularly, not as PRN or as necessary. You really have to keep with this. And what we need is a maintenance or everyday program and a treatment regimen for worsening constipation. And what I usually talk about with patients is they remember gush, push, or mush, push. So that's what you want to say is this is what you want to have for a normal bowel, is that you want to be able to have a bowel movement that is soft, that you can push out without straining. So in summary, if you're a nurse, and especially if you're an oncology nurse, dealing with your patient with pain, you have to be proactive and ask about the bowels. Right at 4 o'clock. Thank you. I was watching my time. It was like, okay, I have till 4. But really, thank you, because as my clinical practice is that of oncology nursing and working specifically with pain. So hopefully this was helpful. Just again, it was a rather quick, broad overview of pain management in oncology care, but hopefully pulling it all together like this in a presentation for you gave you a good synopsis or overview of kind of what I do in clinical practice when I'm working with my oncology patients.